Hello, welcome all to the third session of this year's third GUPS virtual education series on hereditary renal cancer. We have 4 speakers in today's session, and I would request everyone to put in their questions in the chat, and we'll be taking the questions right at the end of once all the 4 speakers have given their talks. I would also, of course, request everybody to be on mute other than the speaker. And of course, no cell phones going off. That would really help. So let me start off. The first speaker today, we have Dr. Tatiana Antic. Dr. Antic completed her clinical and anatomic pathology at Loyola University, followed by a fellowship in oncologic genitourinary pathology and cytopathology at the MD Anderson Cancer Center in Houston, Texas. She joined the University of Chicago in 2009, where she is a professor of pathology and director of cytopathology. She's also the director of cytopathology fellowship program and the co-director of the GU fellowship program. Dr. Antic has co-authored and authored several book chapters and is also the co-author of the book titled Renal Neoplasms, an Integrative Approach to Cytopathologic Diagnosis. She has over 140 peer-reviewed papers and reviews. She has also extensively collaborated on the TCGA urothelial carcinoma project and on numerous radiology projects since 2009 that involved organizing special processing and reviewing of processed specimens. And this collaboration has resulted in numerous abstracts and more than 30 publications. Dr. Antic will present on histopathology and molecular diagnosis for hereditary renal cell carcinoma. Dr. Antic, welcome.
Thank you. I'm going to share my screen and hopefully this is correct view. If not, please let me know. Okay. Thank you all for being here today, and thanks to GUPS for inviting me to talk about my favorite topic, which is kidney. And I'm going to specifically address topics such as histopathology and molecular diagnostics for hereditary renal cell carcinoma. My objectives are to introduce clinical pathologic features, histomorphology, and also ancillary studies that are helpful in distinguishing different hereditary renal cell carcinomas. As you know, hereditary cancer syndromes affecting kidney are very complex, and there are many of them. And because I have only limited time, I'm going to talk only about the ones that are highlighted and that are actually quite, they are most frequent ones. And because I'm a pathologist and I love cases, I talk about cases, I think about cases, I'm going to start with a case. This was actually a young female that, I mean, in my opinion, young female that had already a nephrectomy for clear cell renal cell carcinoma, and now she presents with opposite renal mass and paraadnexal tumor. The radical nephrectomy was performed and actually revealed numerous cysts and occasional solid areas of tumor growth. The paraadnexal mass is obviously cystic, you can see that. And on histology, you can actually appreciate 2 different morphologies. Renal mass is your classic low-grade clear cell renal cell carcinoma with very rich vascular network surrounding small nests of cells with clear cytoplasm and very tiny nuclei, as opposed to paraadnexal mass that was multicystic and solid areas shows tupulopapillary architecture. The cytoplasm is somewhat clear and amphiphilic, and the nuclei are apically located and they are very low grade. Obviously, these 2 tumors are different morphologically. Now, the clear cell follows your typical immunohistochemical profile, which is diffuse box-shaped CA9 that is followed by similar CD10, and then CK7 is negative in this case. as opposed to paranexal mass that is diffusely positive for CK7. CA9 shows cap shade staining, CD10 is negative, and PAX8 is positive. If this was a tumor in the kidney, I'm sure many of you will actually already think about clear cell papillary renal cell tumor. However, this is paranexal mass, and this is actually serous cystadenoma. Now, this constellation of multifocal bilateral RCC with cystadenoma of the parametria already have to have idea that this is probably hereditary renal hereditary cancer syndrome. And in this patient, we already knew that she has von Hippel-Lindau syndrome. Now, when we talk about von Hippel-Lindau syndrome, which is actually the most common of all hereditary renal cell carcinoma, we talk about either a sporadic or hereditary clear cell renal cell carcinoma. However, they all start with a mutation in VHL gene. VHL gene in sporadic tumors acquires two hits. However, in hereditary tumor, because we already have first hit in the germline cells, we just need additional somatic inactivation of VHL gene to cause growth of the tumor. Right now, we know that there are over 400 VHL pathogenic variants, and they are highly penetrant, and therefore 90% of people with VHL syndrome will develop tumors by age of 65. I'm sure that you already know that these tumors are throughout the body, mostly in central nervous system. We are talking about hemangioblastoma, in the pancreas, well-differentiated neuroendocrine tumors, and of course, renal cell carcinoma, and many cysts throughout the body in many different organs. Now, genes involved in CRCC, either sporadic or in this hereditary cancer syndrome, everything starts with VHL. This is in a phylogenetic tree. This is a gene that is located on the trunk. Everything starts with that. And then additional hits can involve different genes, most commonly PBRM1, BAP1, and SETD2 that are located on the same 3P chromosome R. When we talk about how mutation in VHL produces cancer, we know that VHL gene actually regulates production of VHL protein that in this complex keeps in check hypoxia factor alpha. And in a normoxic situations, this complex degrades this factor and then prevents further downstream effects. If you have mutated gene, of course, there is no such inhibition, and therefore accumulation of hypoxia factor will downstream cause cell growth, and especially malignant cell growth and vessels. That's why we have such a vascular tumor in the case of clear cell renal cell carcinoma and retinoblastomas. If you have difficulties diagnosing clear cell renal cell carcinoma, because sometimes they look, especially if they're high grade, then you can use different methods. You can use either FISH to prove 3P loss. You can use also OncoScan microarray, which shows you the chromosomal losses. In here, you see the chromosome 3P loss and amplification of 5. Or you can actually do whole exome sequencing, such in these TCGA study on clear cell renal cell carcinomas, and prove that there's a VHL mutation, 3P loss, or both, and then additional genes such as PBRM1, which is actually most common, and then others such as BAP1 and SETD2. Similarly, hereditary clear cell can also acquire these additional hits. Even though when we think about hereditary clear cell RCC, we often think about low grade, not such aggressive cancers. Now, talking about clear cell, there's also recently described such a syndrome, including germline BAP1 mutation. These patients were usually, in the first cases, first there was described a melanoma with BAP1, then melanocytic tumors, and then the further studies studying all these families with no VHL, they discovered a family with BAP1 germline mutation, and that was their index case. And then they looked into other families and discovered that RCC is very common in families that also have uveal melanoma and malignant mesothelioma. And this incidence of RCC is eightfold more than in a regular population. Therefore, they connected, I'm sorry, they connected this presence of RCC in this BAP1 germline mutation. Now, there's also paper from the French group that talks about also PBRM1 as a germline mutation. However, I didn't see more coming, therefore I didn't include this paper in my presentation. This was about VHL syndrome. The case number 2 is, I'm going to shift to the next one. This was a 29-year-old male with history of tuberous sclerosis that presented with abdominal pain, and CT scan showed 2 distinct tumor masses. The partial nephrectomy was performed, and you can see this solid 1.9 centimeter and this somewhat partially cystic 3 centimeter tumor. As you can see, there's very significant, what we would call capsule in this smaller tumor, and then similar in the larger one with somewhat bands of this, I would call it fibrous tissue, yeah? When you look at the histopathology, you notice that there are these tumor cells that are architecturally in some kind of tubulo-capillary formations or nests. However, they are embedded in this very thick fibromuscular stroma. Looking closer, some of them have more clear cytoplasm, others are more eosinophilic, but even in here, you can appreciate this very thick muscular stroma. Some areas look like your classic, typical clear cell, you would say, with the very prominent capillaries. And in other areas, the nuclei are quite, let's say, ugly looking, and maybe the cytoplasm and whole appearance reminds you of maybe other tumors, such as, let's say, epithelioid angiomyolipoma, and maybe eosinophilic solid and cystic, or something like that. Therefore, this tumor shows different morphologies in different areas, and by immunohistochemistry is diffusely positive in this case with CA9. However, interestingly, the CA9 is not just box-shaped. There's combination of cup-shaped and box-shaped staining. CD10 does not follow entirely the pattern of CA9, and in some areas is negative. And CK7 in this case is focally positive, but strongly. Interestingly, SDHB is mostly negative, except in areas that show more papillary appearance. And in here, we see some weak staining. Now, you probably think about this tumor as what we call rat tumors. And something similar was described in 2 series in 2014 about tumors in tuberous sclerosis patients. And as you can see in here, very similar morphology with very similar immunohistochemical profile with CK7 very positive, CA9, even in here, you can see some cup and box shapes, and then SDHB is negative. In this series, they actually had a case that is metastatic to the lymph node. Because we were very curious about these tumors, why they have different morphologies, different immunohistochemical patterns. We actually collected 15 cases and we did immunohistochemistry and molecular studies. And we actually realized that they are not uniform category of tumors. Actually, there are 3 different tumor types, as I would say. We had 3 cases that have so-called, now it's ALOC mutated. We had cases that are clear cell papillary renal cell tumors. At that time, they were carcinomas. And then we have this category with tumors that have TSC mutations. This patient that I just presented is actually one of these patients with tuberous sclerosis. We were then interested in this specific category, and we expanded our study and looked into only this type of tumors with TSC mTOR mutations, and we found some interesting immunohistochemical staining. As I said, usually the staining is combination of CAP and BOX. CK7 is always positive, but not entirely diffusely strongly or anything like that. We also found that these tumors stain for CK20 occasionally, and some papers that came also later on showed the similar findings. And SDHB, even though can be entirely negative, it's mostly positive in these tumors. And this is actually molecular finding in the person that I presented that had tuberous sclerosis. Now, having all this said, because it's really hard to sometimes differentiate them just by histology and by immunohistochemical staining. This is a recent paper that came that talks about GP and NMB immunohistochemical stain that is actually specific for mTOR pathway, not specific for the tumor type. In this case, they stain cases that are ALOC mutated, actually mTOR TSC mutated, some clear cells and some clear cell papillary renal cell tumors. And they found that all these with mTOR in the mTOR pathway stain with this immunohistochemical state strongly and diffusely. And they only found that 2 of clear cells have some staining. Now, I have to slightly curb your enthusiasm about this stain, because it turned out that this stain also is positive in translocation renal cell carcinomas, as well as other oncocytic tumors that have TSC mutations. Of course, oncocytic tumors we can morphologically put in a different category, but translocation renal cell carcinomas sometimes can be very difficult and can show similar tubular papillary clear cell abundance cytoplasm. Therefore, combination of things should be used. However, this is a very exciting immunohistochemical stain if you are lucky and your lab can perform it. These same 2 large papers talking about tumors in tuberous sclerosis patient describe tumors that now look to us as either a low-grade oncocytic tumor, or maybe they look like eosinophilic vacuolated tumor, or even eosinophilic solid and cystic carcinoma. All these tumors are described in patients with tuberous sclerosis, and we now know that most of these tumors actually do have TSC mutations. But I'm not going to dwell on these oncocytic ones. Now, there are 2 peculiar things about tuberous sclerosis. We call the tuberous sclerosis as a hereditary syndrome. However, many patients actually have germline TSC mutations that are de novo. Their parents don't have anything. It's not inherited from the parents. They develop de novo these germline mutations. And the second peculiarity is that some of the tuberous sclerosis lesions don't show second hits. The second hits, meaning either second somatic mutation, deletions of the chromosomes, and so on and so on. And some people think that actually just inactivation of TSC and less production of tuberin and hamartine can cause actually less inhibition on mTOR pathway, and therefore the mTOR pathway is activated and the cell proliferation happens. Anyway, these patients are recognized early in their infancy because they can even get born with, let's say, myocardial rhabdomyomas. They can develop early seizures and skin lesions that can be easily recognized. However, as I mentioned, there are two peculiar things about this tuberous sclerosis syndrome. Now I have just to take a little break, have a little bit of water, and I will continue. Now, case number 3. This was a 30-year-old female with history of uterine fibroids and skin lesions, again presented with abdominal pain, and the CT scan actually shows cystic 4.5 centimeter tumor that is arising from the lower pole of the right kidney, and this unfortunate person has also multiple liver lesions. Looking at the tumor, you can appreciate how cystic it is. There are multiple cysts that are lined by these somewhat hobnail type of epithelium, and it might actually make you think about specific cancer called tubulocystic carcinoma. However, other areas had this nested tumor cells in somehow looking also as forming some cribriform structures. Again, in here, you can appreciate better that the cysts are lined with this hobnail, high-grade epithelial cells, and they show also this very cherry red nucleoli with some perinuclear halos. We do not have specific immunohistochemical stains that I'm going to talk about later, but we did sequence this case, and it showed a frameshift mutation in FH gene, and the frequency of this mutation was 66%. Now, this is some kind of a way of cheating, if you will. When you have frequencies that are more than 50%, you often have to think that this is a germline mutation rather than affecting both alleles, rather than just a somatic mutation. This person did underwent a germline mutation, and she did have a FH gene mutation. Therefore, even though it's not perfect, very often these frequencies can point out towards a germline mutation. And the liver biopsy, unfortunately, this was a metastatic RCC. This is a PAX8, showing similar morphology, high-grade, somewhat cribriform, tubular, and papillary architecture. This is obviously hereditary leiomyomatosis and renal cell carcinoma syndrome, or what we prefer to call fumarate hydratase deficient RCC, because very often we do not have any information about either a germline mutation or about other tumors in this syndrome. What happens with this gene is that mutations lead to loss of or reduction of FH enzymatic activity, and FH plays role in Krebs cycle. And this causes accumulation of FH in the cells. This whole process leads to anaerobic glycolysis and other tumor-related functions. And all of these cause tumors in the uterus and skin, as well as RCC. This syndrome was actually described in 1973, but didn't make connection with RCCs. And the name comes from 2001 paper where two Finnish families were described, and this connection with RCCs was established. Many studies show that this mutation is quite frequent. However, it seems that it's not highly penetrant, and that's why not many people develop all these very aggressive tumors.
Dr. Antich, could you please summarize? I think, sorry, we have time constraints, and if you can kindly summarize your talk. Thank you.
Thank you. Anyway, obviously, I'm going to finish with this. These tumors were described in 2007. They are all CK7 negative, and then immunohistochemistry that is now used is FH negative to SC positive, and some tumors actually do not show this kind of staining or don't have specific mutation. And the low-grade tumors FH deficiency are also described. I use Vimentin to separate these, and I think the Vimentin is highly helpful. And just to say that these viral-like inclusions are not specific for FH because we found them in also other papillary renal cell carcinoma type 2. And I'm going to finish my presentation. I'm sorry that I went over time. My summary is that hereditary renal cell carcinomas occur predominantly younger patients and are frequently multifocal and bilateral. That classic morphology is usually found at least focally, and therefore general sampling is recommended. And that histomorphology is variable and overlap. And that even though immunohistochemical profile is helpful, molecular confirmation of the specific mutation is preferred. And thank you. I'm sorry I went over time. This is our campus at the University of Chicago.
Thank you, Dr. Antich, for this very insightful presentation. We appreciate that. Hello, everyone, and good afternoon or good evening, wherever you are. I am Rohit Mehra, GU pathologist at University of Michigan. I'm excited to be here today and pleased to introduce our second speaker, Professor Virginie Vercaret. She'll be presenting her talk entitled Overlapping Pathologic Features of Hereditary and Sporadic Renal Neoplasia. Professor Vercaret is in charge of uropathology at the Department of Pathology in European Georges Hospital located in Paris, which is a part of the Paris Cancer Institute. She's a pathologist expert of the French Hereditary Kidney Cancer Network and also deeply involved in the French Curare Network, which is a multidisciplinary initiative to better patient care. We look forward to your talk, Virginie. Thank you.
So, hi. So, could you see my screen?
Yes, please. Please go ahead. Thank you.
Yes, so thank you, Rohit, for your introduction, and I would like to thank GUPS committee for your invitation, and I'm delighted to participate to this session on hereditary disease and to talk about overlapping pathologic feature of hereditary and sporadic neoplasm. So to introduce, 5% of renal tumor in adults are associated, as you know, with hereditary predisposition. Identification of hereditary predisposition is essential to provide appropriate medical management for patients and their relative health risk. Indication for genetic counseling depend on clinical and some pathological criteria. As you know, pathologists have an important role to play in the diagnosis of hereditary renal tumors, specifically in some FH of SDH deficient RCC, for example. So,
hi, Dr. Vercaret. Do you want to hit the presentation button at the bottom of your screen to make it full screen?
I try, but
oh, no worries. We can work off of this. Thank you.
So I try, and just a second. Sorry about that. Okay. Is it okay?
It looks perfect. Thank you.
Just a second more for me. So hereditary syndromes have contributed, as you know, to improve understanding of renal oncogenesis and to the discovery of new systemic therapy. In-depth genetic analysis of renal tumor also revealed common oncogenesis pathway between sporadic and hereditary renal tumor. And molecular and immunohistochemical study carried out by pathologists have also led to the discovery of new entity, as you know. Depending on the tumor, there may be one or more predisposition gene to look for, and this justifies utility of multi-gene panel testing. So in sporadic setting, somatic molecular analysis is also helpful for routine diagnosis and for identification, of course, of target therapy in metastatic cases. So just, yes, because is I with my, okay, sorry. So 95% of sporadic tumor, 95% of tumor are sporadic. So which tumor overlap with hereditary syndrome? So a large number of tumor represented by red area, but I'm not going to have time for all of them. And of course, I will highlight some detail for clear cell RCC, papillary RCC, and all of tumors associated with TSC-mTOR alteration. And as you know, chromophobe and oncocytoma could be associated with BHD syndrome or some rare Cowden syndrome. And Dr. Tatiana Antic told you about FH and SDH deficient. So let's start with the best candidate is clear cell RCC and VHL. As you know, inactivation of VHL is the hallmark of clear cell RCC in VHL and the sporadic context, of course. And on microscopic examination, it's almost impossible to distinguish if it is an hereditary cases or sporadic case. VHL has been identified in 1973 and could manifest firstly by only RCC in very rare cases, less than 10%, at median age of 37 years. So the unique context, the clinical context is very important, and as you see, in VHL disease, you can have a lot of renal tumor and together with renal cyst, whereas in sporadic setting, as you know, it will be more often a unique tumor. So let's continue with clear cell RCC. Clear cell RCC with loss of BAP1. BAP1 is a tumor suppressor gene, and as Tatiana Antic told you before, BAP1 familial predisposition, predisposing syndrome is very rare, but can be associated with clear cell RCC, and BAP1 germline mutation have been identified in less than 1% in TCGA study. In contrast, BAP1 somatic mutation is more often in sporadic context and have been identified in almost 10 to 14% in TCGA, for example, but in sporadic context, BAP1 mutation is a subclonal mutation. So in both conditions, hereditary or somatic, you can have a loss, you can identify a loss of expression with BAP1 antibody, like in the picture on the right. But in the somatic, in the sporadic context, of course, BAP1 have been associated with a worse prognosis, and it has been demonstrated by a beautiful study by Samrat Turajic. And BAP1 confer rapid progression through metastasis cases. However, if we detect in a RCC, in clear cell RCC, distinct area with one positive and one negative, it should be more sporadic BAP1 mutation rather hereditary mutation. So let's move to the papillary RCC and oncogene meet. Papillary RCC, as you know, is an heterogeneous RCC with type 1 and type 2 identified in 1997. And as you know, papillary could be more often multiple compared to other RCC, could be very rarely associated with hereditary predisposition, such as BHD syndrome or hereditary papillary RCC, which I'm going to detail. Hereditary papillary RCC is a very rare hereditary disease without extrarenal manifestation, and is the only one without extrarenal manifestation. Is due to germline mutation of proto-oncogene MET localized in the long arm of the chromosome 7, and is the only hereditary disease associated with a proto-oncogene MET encode for the transmembrane receptor tyrosine kinase MET activated by AGF. So in hereditary papillary RCC, the tumor will be very frequently multiple and bilateral, and were associated with almost only papillary type 1 RCC, which are mostly low-grade RCC. And of course, you can find also a papillary adenoma. In 2017, we have identified the 4 cases of biphasic squamoid alveolar papillary RCC in a family of hereditary papillary RCC, which pop up to support the continuum between papillary type 1 and biphasic squamoid alveolar papillary RCC. So in sporadic papillary RCC, more common MET alteration have been identified in type 1 compared with type 2. And as you know, we can have a lot of gain of chromosome 7 together with few MET mutation, 17 to 33 mutation in type 1 and less in type 2. In a very interesting and recent retrospective study on 158 patients with papillary type 1 RCC, screening from constitutional MET pathogenic variant demonstrate that 12% harbor germline MET mutation, up to 40% if patient had a familial history, and up to 33 if tumor were bilateral or multiple. So if you focus now on the variant of papillary RCC, which have been described in 2016 by Hess, named the biphasic alveolo-squamoid papillary RCC. Most cases are sporadic, but as I told you before, there is some case associated with hereditary papillary RCC. In our French monocentric series of 17 patients, we identified 60% of MET variation in tumor, and 4 patients had hereditary papillary RCC with 2 new cases, including 1 with only 2 tumors without family history. And somatic MET alteration was also observed in the 44% of tumors. This year, Luis Nova Camacho also described additional 13 cases and found 31% of MET mutation. So today there is more than 91 cases published, and most of them are multifocal, has papillary type 1 RCC, and less than 10% may develop metastasis. So let's finish with a big part of the overlapping pathologic feature, which concern, of course, as you know, TSC mTOR-associated renal tumors. And as you know, renal tumor, TSC1 or mTOR gene are mutated secondary in a more common subtype, but in less than 10%. So in TSC mTOR driver tumor, hyperactivation of mTOR pathway may occur either by two circumstances, either by biallelic inactivation of tumor suppressor gene, either in TSC1 or 2, like in TSC setting, but also could occur in the sporadic setting. And the second way is by activating mutation of mTOR, mammalian target of rapamycin, and this could arrive only in sporadic cases. In both conditions, overactivation of mTORC1 may be confirmed by immunohistochemistry of downstream targets such as CAT4, HBP1, and S6K. So historically, overlapping tumor associated with mTOR are represented by angiomyolipoma and epithelioid angiomyolipoma, and most frequent, which is the most frequent tumor in TSC, but is also the most frequent mesenchymal tumor in sporadic context, and past decades have identified also mTOR mutation or TSC1, TSC2 mutation in such mesenchymal tumor. And in renal cell tumor, as Tatiana Antic previously highlighted, two independent series describing such tumor occurring in a TSA context have been published in 2014 that paved the way to the description of new entity, as you know, NAR, and the GUPS, in 2021 highlight that mTOR pathway was found more recently to be primarily involved in the pathologies of specific pink tumors such as ESCRCC, eosinophilic vacuolated tumor, low-grade oncocytic tumor, and also in RCC-FMS, even in sporadic context, which now appear to be more frequent than in TSC setting. So there was in March 2022 a special, look-like special issue focusing on 3 of them, and Rohit Mehra together with Argani write a beautiful editorial. And this special issue include two articles focusing on low-grade oncocytic tumor and with alteration of mTOR pathway. Also together with eosinophilic vacuolated tumor, which identify also TSC mTOR mutation. And the third one was identification of TSC loss in eosinophilic solid and cystic tumor. So I don't take a lot of time for RCC with fibroleiomyomatostroma because Tatiana Antic told you before. NAR in Gupta et al. Identify in the recent series of TSC patients also a lot of RCC with fibroleiomyomatostroma, which seems more frequent than other entity. So in sporadic counterpart, to morphologically identical tumor occurring in TSC patient associated with recurrent mutation in TSC1, TSC2, and mTOR, sorry. 3 series have highlighted the sporadic counterpart and molecular alteration. And it has, Tatiana Antic told you, it's sometimes very difficult to distinguish with a TCB1 mutated tumor. So let's share cases from our cohort of HGP. It was a case from a female of 73 years old without known TSC, unique tumor less than 4 centimeters. Morphological feature was consistent with the RCC-FMS with the immunohistochemical profile typical. So the hypotheses were RCC with TCAB1 mutation, RCC with FMS with mTOR alteration pathway. So next generation sequencing allow us to identify a pathogenic variation of mTOR with allelic frequency of 29% that allow us to confirm the diagnostic of RCC FMS, so associated with mTOR alteration of mTOR pathway. So for eosinophilic solid and cystic RCC, it's the same story. This entity have been described in 2016 by Trepkov and al. In the first series of 16 tumors are occurring in the sporadic context in women. And all the morphological and the immunohistochemical were consistent with sporadic counterpart of 6 cases described in TSC. So they highlight the patchy to diffuse positivity of cytokeratin 20, which have not been reported before in TSC tumors. So as you know, in 2 years after, a molecular analysis demonstrates somatic alteration of TSC1 and TSC2 in sporadic cases, which have been confirmed in the last report by Murani 2 years ago. And Rohit Meha largely contribute to the identification of the somatic biallelic loss in sporadic cases, which is very frequent and present in 85% of cases. So if you move with eosinophilic vacuolated renal tumor is at least the last tumor before LOX. It's another oncocytic tumor of the kidney. Just detail in the other oncocytic tumors of the kidney in the WHO classification. So the immunoprofile is the same as oncocytoma tumor, and we can distinguish them by morphological feature, like the terminology vacuolated renal tumors with prominent nucleoli. And first sporadic case have been described in 2018 with also involvement of TS of mTOR pathway gene. And later, it seems that TSC tumor occurring in the TSC is relatively rare, and it have been identified in only a few cases. So now we can see, we know that 19 tumors studied this year underwent also TSC1 or mTOR mutation. So the last tumor will be a low-grade oncocytic renal tumor, firstly identified by Trepkov in 2019, and also identified as other oncocytic tumor in the kidney in the WHO classification. Its diagnostic is more easier because there is a very recurrent phenotype distinguished to oncocytoma and chromophobia. And also, we have identified together with another group in 2021 mutation in TSC1 pathway, mostly in mTOR gene that seems to be associated more with a sporadic context rather in TSC setting, in which it has been observed in very rare cases, like this case reported by Lerner and al. Together with other tumor associated with TSC1 alteration. So I will finish with a big review published this year, underlining also that 77% of lots is now associated with genetic alteration of mTOR pathway. So I would like to thank you for your attention.
Thank you, Dr. Warkari. That was a great talk. For our next talk, we have Dr. Mark Ball. He's an associate professor and associate program director of the Urologic Oncology Fellowship at the National Cancer Institute of the NIH. He received his medical degree from Johns Hopkins and completed his residency at the Brady Urologic Institute at Johns Hopkins as well. And he did his urologic oncology fellowship at the NCI, where he worked in the lab of Dr. Marston Linehan. Dr. Ball has been the recipient of several academic honors, including Outstanding Laparoscopic Surgeon from the Society of Laparoendoscopic Surgery, Outstanding Research from the SUO, and he's the recipient of an LRP award from the NIH and multiple teaching awards. And, we've both Dr. Antich and Dr. Warkari have shown us how we are increasingly diagnosing hereditary renal tumors, and Dr. Ball will be able to give us his perspective on surgical intervention of these tumors. So thank you, Dr. Ball, for joining.
Well, thank you so much, and good afternoon from Bethesda, Maryland, to everyone on the call. Really appreciate GUPS for the invitation to speak today on the surgical management of hereditary kidney cancer. I have no financial disclosures. I would be remiss without saying that I've benefited greatly from my relationship with pathologists, especially GU pathologists, since I was a medical student when I did a GU path rotation. And not only do I collaborate in a research capacity often, but I couldn't practice clinical medicine without the GU pathologists that I work with every day. So my objectives for this talk is to discuss the surgical management of patients with hereditary kidney cancer syndromes, which we've already heard a lot about today, with a focus on, for me, when and how we intervene. I will say that anytime we're talking about a set of rare syndromes, we use a framework, but we recognize that all models are wrong, but some are useful. So the models I'll present today are useful in 2024, are subject to change. So unfortunately, this is a little bit pixelated, but these are radiographic images of 4 renal masses, not otherwise specified. These are all between 2.5 centimeters. They all abut the sinus fat on imaging. And in my field, in urology, a lot of times the surgeon would stop here and they would say, okay, I have enough information. Let's go ahead. In most of these cases, actually, they would probably take out the entire kidney. In centers of excellence and academic centers, they would perhaps do a partial nephrectomy. And, we'd sort of sort out what's going on afterwards. We underutilize biopsy, and we underutilize really molecularly characterizing what we're doing until after the fact most of the time. But my argument is that molecular characterization not only can it guide our treatment, it really should guide our treatment, because I would do different surgeries for these 4 tumors if I had more information. So again, my field is a little bit behind the 8 ball. We talk about kidney cancer as if it's one disease. Everyone on this call knows that it's a collection of different diseases that happens to arise in the same organ. Different histologies, but also different responses to systemic therapy in the advanced setting, but also different techniques, different surgical techniques can be used to manage these different tumors. Now, I hope it's not anathema in 2024 to still have papillary type 1 RCC on a slide, but I find that designation actually still very useful. I understand type 2 is a little bit of a bucket, good with getting rid of that, but just my innocent plug from a surgeon to a group of pathologists. But anyway, we'll see how maybe we think surgically about these diseases slightly differently. Now, there are at least 12 known syndromes that confer a predisposition to kidney cancer. And the textbooks say somewhere between 5 and 8% of kidney cancers are associated with a known hereditary kidney cancer syndrome. But in my training, new syndromes have been described just in the last few years. We know that upwards of 25% of cases, maybe a little bit overstated, but in some series, 25% of cases can have multifocal involvement. Now, we just heard in the last talk, especially with papillary kidney cancer, but in a variety of histologies, whether that's bilateral involvement, multiple tumors within the same kidney, or even a large single index tumor with multiple satellite or incipient lesions near it. All that to say that hereditary kidney cancer is probably underappreciated. Now, managing these patients surgically can be challenging for a variety of reasons. This is a gross specimen of a kidney of a patient with VHL that I removed a few years ago, and you can see there are multiple kidney tumors throughout the kidney, but this patient had also required before this multiple operations. We take these out, we kind of reset the clock, but they keep coming back. So really, it's our job to balance a few competing risks, and that's the risk of developing metastatic disease, but also the risk of renal functional decline, trying to keep these patients off of dialysis and really maintaining their quality of life. So I will share a few insights that we've garnered over the years to help with each of these goals. Now, a lot of times, patients that are referred with hereditary kidney cancer, again, maintaining renal function is of paramount importance. So it forces us into some situations where we have to maybe do some more complex surgeries and more, quote, heroic partial nephrectomies than we would in the sporadic population. And these are all patients we've managed here at the NCI over the past few years. And any names on the slides are actually the ordering providers, not patient names. I think moreover, and this I think meshes well with the last talk we heard, is not only is there overlap with some of the sporadic kidney cancers that we see, but hereditary kidney cancer is really a great, clean model to study the biology of kidney cancer writ large. And knowing how these tumors behave can maybe inform us about the larger world of kidney cancer. So to that end, clear cell kidney cancer is well encapsulated by the von Hippel-Lindau syndrome, papillary type 1 by the hereditary papillary renal cancer syndrome. Chromophobe, we of course see in Birt-Hogg-Dubé syndrome, and papillary type 2, don't throw tomatoes, is seen in hereditary leiomyomatosis and renal cell carcinoma, or HLRCC. So I would argue that knowing not only the pathology, but the genes driving these tumors can dictate a few things. Number one is when to operate. In other words, when do we do surgery? When can we watch and perform active surveillance? But also how to operate. And this gets back to that first slide that I showed with the 4 tumors. How do we approach them? Do we have to take out the whole kidney? Can we take out just a nucleation? Do we need to take a margin? Do we need to perform a lymph node dissection? So just going into detail in just the most common syndrome, VHL, a little bit more. We've already heard about it a couple of times already, but a autosomal dominantly inherited multi-organ cancer syndrome. Patients get hemangioblastomas of the brain and spinal cord, angiomas of the retina, of course, endolymphatic sac tumors of the inner ear, pheochromocytomas of the adrenal gland, and paragangliomas elsewhere in the sympathetic chain, both cyst and neuroendocrine tumors of the pancreas, solid and cystic masses within the kidney, and then cystadenomas, as we saw already, of the broad ligament in women and in the epididymis in men. The NCI has been a referral center for VHL for a few decades, and we've had the opportunity to really understand the natural history of VHL. And our initial observations, I say my boss, Dr. Linehan, Marcin Linehan's initial observations were consistent with the sporadic population in that an increasing size of a tumor was associated with increasing metastatic potential. And so a number of years ago, a threshold of 3 centimeters was developed. In other words, that we would perform active surveillance for small tumors and intervene when they reached 3 centimeters. And we extended that not to just VHL, but also to hereditary papillary RCC and also Birt-Hogg-Dubé syndrome. And again, this really a 3 centimeter guideline. Once the largest gets to 3 centimeters, we try to take out all the tumors that we can safely. But inevitably, not every patient is managed with this 3 centimeter guideline. In fact, we still see a number of patients who come in with larger tumors, either because it's a new diagnosis or because of complex referral patterns or maybe loss to follow-up. And it gives us a chance to compare the rate of metastases from small tumors to large tumors. And so when we looked at this, we've screened 764 patients with VHL here. The majority of them have developed kidney tumors at some point. And following them for almost a median follow-up of almost a decade, we see that patients who were managed exclusively by the 3 centimeter tumor versus 3 centimeter guideline versus those who haven't. And unfortunately, about 10% of our patients have developed metastatic disease. And we can see that there is a clear correlation between the size of the largest tumor and metastatic potential. So for the 178 patients that never had a tumor greater than 3 centimeters, none of those patients developed metastatic disease. But sort of in a stepwise pattern, with increasing tumor size, the metastatic potential has increases significantly, to the point that by the time you get to 7 centimeters, it's actually the majority of those patients who develop metastatic disease. And then looking across some of our other syndromes, Birt-Hogg-Dubé syndrome and HPRC, we see the same thing. In fact, in Birt-Hogg-Dubé syndrome, even under 4 centimeters, no patients really develop METs. And only really one patient under 7 centimeters, while once we get to a large size, over 7 centimeters, we do have about a 30% metastatic rate. Likewise, in hereditary papillary renal carcinoma, really the majority of metastatic cases are for those larger tumors greater than 7 centimeters, really only one with metastatic disease under that 3 centimeter threshold. So sort of taken together then, when to operate? Well, I think it's pretty clear from these data that 3 centimeters is not a bad guideline. It's not, once someone crosses that 3 centimeter threshold, it's not an emergency. They don't have to have surgery tomorrow, but that's when we start planning for surgical intervention. You may ask, well, why not wait until a tumor reaches 7 centimeters, if, especially for a Birt-Hogg-Dubé or HPRC patient, if their metastatic potential is so low? Well, it turns out that technically it can be a little bit more challenging to remove a larger tumor, and oftentimes we get more collateral damage in terms of declines in renal function. So for both oncologic and renal functional outcomes, 3 centimeters remains a convenient guideline for when to intervene. We also have had the opportunity to study the growth rates of genetically defined tumors in patients undergoing active surveillance. So this was a study we published in JCO a few years ago now, looking at 4 different germline altered tumor types: those that are BAP1 deficient, VHL deficient, MET activated, and folliculin deficient. And we saw there were distinct patterns of growth. BAP1 deficient tumors had rapid growth rates. This is just one patient, not the pooled analysis, but this patient grew at almost 1 centimeter a year, while VHL deficient tumors grew at half that rate. MET activated and folliculin really at 1/4 of the rate of VHL. So 3 kind of different tiers of growth. And so when we are doing active surveillance, this can help us know how often to image patients and how to kind of predict when they may reach that 3 centimeter threshold. Now, we talked about now when to operate, but how do we operate? How do we decide on a few different techniques? And I really break that down into 4 axes surgically of how we think about treating tumors. Traditional open surgery versus robotic surgery. Do we go in from the front or the back with a transperitoneal versus retroperitoneal? Something that we definitely rely on our pathologists for to help us with is margin assessment. And when is it safe to do a tumor enucleation? Sometimes even seen this called tumorectomies in path reports, versus a wide excision, a traditional partial nephrectomy with a margin. And when do we clamp the blood supply to the kidney or not? And I will say that traditionally, a lot of patients who have hereditary kidney cancer syndromes with multiple tumors requiring multiple operations, those patients were managed with open surgery. And while there's nothing wrong with that, what we have seen is that sort of serial open surgeries beget complications. These are big surgeries, and it causes a lot of scar tissue around the kidney. So we do try to prioritize doing minimally invasive surgery when we can to limit sort of the surgical footprint and the scar tissue and inflammation around the kidney for future surgeries. In patients managed with open surgery, it's not uncommon to see sort of multiple incisions. This is a midline incision, kind of multiple levels of incisions between the ribs and in the back to get to the kidney. And on radiographically, we can see all the old clips from surgeries. All these are associated with fibrosis and scarring and can make things challenging. When we studied outcomes at the NCI of patients with just what I was describing, open versus robotic surgery, we found that when we do robotic surgery, we can usually do that with less blood loss. We can do that with fewer complications. And for that reason, we have some data to support doing that when we can. In other words, avoiding a big open surgery. Now, again, maybe a little bit more germane to this audience, margin status. So why consider doing a traditional partial nephrectomy versus a tumor nucleation? Well, in a patient with a hereditary kidney cancer syndrome, where they may have a dozen or more tumors throughout the kidney, if we take a margin with each tumor, at some point we're not going to have a lot of kidney left. So we really try to prioritize tumor enucleation when we can, as long as it doesn't have a negative impact on oncologic outcomes. So the benefits then of tumor enucleation, obviously we, by definition, preserve more normal kidney parenchyma. We can also sort of follow the borders of the tumor, as everyone here knows that clear cell kidney cancer often has a nice pseudocapsule. So in VHL, we really have a tough rind that we can separate normal parenchyma from tumor. And because of that, we tend to avoid deep structures of the kidney, avoid collecting system injuries, avoid getting into large blood vessels, and it can be helpful. So what does that look like surgically? This is a video of a robotic surgery where we are removing a tumor, and this is a clear cell tumor that has a nice rind, and we can really cut the capsule of the kidney and then just kind of push on the tumor and almost just roll these out. And the blood supply to the kidney is not clamped here. And so being in this nice plane allows us to really do this with pretty low morbidity. Now, shifting gears a little bit, very different entity is HLRCC. This is films from a patient that had a radical nephrectomy elsewhere and then presented to us with a sort of cystic collection with some solid material in it that ended up being basically a retroperitoneal recurrence of HLRCC after a radical nephrectomy. And these are actually two different patients, but similar presentations, kind of cystic solid retroperitoneal recurrences. And what we've seen in HLRCC is the metastatic potential is a lot different. In fact, we've seen patients with a sub 1 centimeter tumor with metastatic spread, with metastatic disease, and we really see across the boat metastatic potential, obviously very high with big tumors, but it's not zero with small tumors. So for this reason, we never perform active surveillance for HLRCC. If we see a tumor, we take it out before it has the chance to get bigger. So sort of to summarize then how to operate, well, the approach, it's really at the surgeon's discretion in terms of robotics or open surgery. It casts no stones there, but it's my opinion that robotics can minimize scarring associated with fewer complications. But I still do open surgery for HLRCC because we've seen sort of some atypical recurrences, and it has a propensity to to have peritoneal spread, especially if a tumor is ruptured. So for that reason, kind of perform traditional open surgery. In terms of the extent of resection, how much margin we take, do pretty tight enucleations for VHL, for Burkhard-Dubé, for HPRC, but I take a wide margin for HLRCC. For those same reasons, I don't want any tumor cells exposed. And in the same vein, we do that for SDH deficient tumors. So let's come back to this, this intro slide. 4 masses not otherwise specified. Well, what if I told you the first patient had Burkhard-Dubé, the second von Hippel-Lindau, the third BAP1 predisposition syndrome, and the fourth HLRCC, which is the case. These are all patients that I've seen and operated on. Well, we would actually approach these very differently. For a 2.5 centimeter Burkhard-Dubé tumor, doing active surveillance. We know these tumors grow slowly, so I don't need to see them again for 2 years because it's going to be several years before this gets to that 3 centimeter threshold that I'm worried about. And when it's time to operate, I'm going to do robotic surgery. I'm going to enucleate the tumor and with very little margin, and that patient's going to do well oncologically. Patient number 2, von Hippel-Lindau, also a 2.5 centimeter tumor. I'm still going to do active surveillance, but I want to see this patient next year because these grow sort of 3 to 4, up to 5 millimeters a year. Next year, it's going to be close to time to operate. I'm still going to do robotic surgery with the tumor enucleation. Patient number 3, BAP1, 2.5 centimeters. These tumors can grow quickly. So I'm going to talk about surgery now. If the patient wants to do active surveillance, I'm going to see them back in 6 months because I don't want to lose my window to intervene. I'm going to do robotic surgery, but for this one, for now, I'm going to also take out a margin. We don't know as much about BAP1, but there are some signals that if it's more aggressive, we're probably better off taking a margin of normal renal parenchyma with it. And finally, the smallest tumor on the picture here, HLRCC, it's only 2 centimeters, but it's deep and it's abutting the sinus fat. Well, I'm going to recommend immediate surgery for this patient, no active surveillance. And I'm going to strongly consider open surgery. And for this one, I'm strongly going to consider doing a radical nephrectomy rather than a partial nephrectomy if I think that I cannot get an adequate margin of at least 5 millimeters, if not more. I'm also going to have a low threshold to take out regional lymph nodes with an HLRCC solid tumor. Now, going over these types of cases in our tumor board a few years ago, when Ned Sharpless was the director of the NCI, he raised his hand when he was visiting and asked, "Are you telling me that knowing the genes is going to impact the type of operation you do?" And I said, "Yeah, yes, sir, Mr. Sharpless, Dr. Sharpless." And he said, "Wow, this is not just precision medicine. This is precision surgery you're describing." And so we like that term. We kind of use that now to discuss how we manage hereditary kidney cancer. And again, we would be remiss to not acknowledge the role of pathology in everything we do. We try to use the operating room as an extension of the lab. We annotate our tumors before we take them out. We get them out, and while we're still in the operating room operating, we have both our pathologist and our lab tissue procurement team taking samples to do any types of metabolic studies we may be doing, genetic studies, etc., while keeping us honest with our margins. So in closing, I would argue that knowledge of pathology is really critical to what we do, and not just the histopathology, but also molecular analysis, knowing the driver genes. With somatic alterations, germline alterations, they can inform us with growth rates, metastatic potential, and our tumor-parenchyma interface, so how we think about margins. And for any patient with a risk factor for hereditary kidney cancer, we strongly recommend screening with a genetics counselor, and I have a pretty low threshold to do germline genetic testing. Thank you all for your attention. Again, this is a team effort in any sense. Maria Marino, and our pathologist, is a wonderful collaborator, and I couldn't practice medicine without her. And look forward to any questions at the end of the talks. Thank you very much.
Thank you, Dr. Paul, for that excellent talk. It gives me great pleasure to introduce the next speaker, who is the last speaker in this session, Dr. Pavlos Misol is an assistant professor in the Department of Genitourinary Medical Oncology at MD Anderson, and he has a dual appointment in the Department of Translational Molecular Pathology. He's a physician scientist dedicated to research on RCCs with a particular emphasis on rare variants such as RMC, that is renal medullary carcinoma. He has co-authored and authored over 170 articles in peer-reviewed journals. His laboratories identified distinct genomic and immune hallmarks of RMC and developed testable models of RMC pathogenesis, resulting in the identification of high-intensity exercise as the risk factor for RMC. He serves as the principal investigator of several completed and ongoing investigator-initiated clinical trials of rare and common renal cell carcinoma, including the first such trial designed specifically for RMC. I welcome Dr. Misol. His talk is on HIF2 alpha inhibitors in the management of kidney cancer. Thank you.
Thank you so much for the kind introduction, and thank you so much for having me. Same as Dr. Ball, I am always very appreciative of our pathology colleagues. We just hired a clinical pathology trained research scientist in my lab, exactly because of the value that we believe pathology has. And same as when I look at radiology and imaging, every time I see a patient in my clinic, I actually look at their pathology slides as well. They provide immense value. So it's a pleasure to talk today about the HIF2 alpha inhibitors in the management of kidney cancer from a med-onc side. These are my disclosures. None are related to today's talk. And as you can see, and you all know, there has been tremendous progress in the past 15 to 20 years in developing systemic therapies for kidney cancer, using different MOAs, target therapies, and immunotherapies, with belzutifan, the first HIF2 alpha inhibitor to receive approval for sporadic clear cell renal cell carcinoma in the salvage setting in December 2023. It's the most recent one. What I do want to highlight, and it is important to keep in mind from the pathology standpoint, all of these approvals were based predominantly, or in many cases really exclusively, in data from clear cell kidney cancer trials, not on studies in other histologies, highlighting how important it is to make an accurate pathological diagnosis. It guides our systemic therapy management immensely. And this is a vision largely by Marston Linehan of subtyping, of thinking of kidney cancer not as a single entity. Shown here is the most common one, clear cell renal cell carcinoma. You will excuse me for still also using type 1 papillary for now. And you can see here 25%, that's a big number. That means I only see patients with kidney cancer in my clinic. So that means that 25%, honestly, in my case, 30 to 40%, is actually non-clear cell renal cell carcinoma entities that I see every week. And they are very different from each other. And related to the HIF2 alpha pathway, there are a few high-level concepts that can help us even distinguish how each one of these subtypes may behave to HIF2 alpha inhibition, but they're also useful concepts to teach us a lot about the hallmarks of cancers in general. And the first one would be this idea of pseudohypoxia as opposed to, normoxia, which happens in clear cell. This is a hallmark of clear cell kidney cancer, where due to the VHL loss, clear cell kidney cancer believes it is hypoxic. It's not, it may or may not be hypoxic, but it believes it is. And it produces these factors, including HIF2 alpha, to create certain conditions, including increased vasculature, to provide to itself more oxygen. Now, A similar process through a little bit different pathways happens to some other subtypes, including F8 deficient kidney cancer. And how does that help us? We can predict, for example, that F8 deficient renal cell carcinoma should also be sensitive to targeting angiogenesis using VEGF pathways and also HIF2 alpha potential inhibitors, although this remains to be seen. And another one, again, associated close to this pathway is STH deficient renal cell carcinoma or STH deficient other tumors like pheochromocytomas and paragangliomas, in theory, should be susceptible to targeting this pseudohypoxic derived pathways. And so in general, whenever you have a tumor driven by pseudohypoxia, you should on average expect that it's going to respond to the anti-VEGF therapies developed for clear cell kidney cancer. And there are differences, though. It's not like, oh, all of them are going to behave the same way, because, for example, whereas clear cell kidney cancer does respond fairly well to the currently available immune checkpoint therapies, F8 deficient RCC and STH RCC can occasionally respond, but not nearly as often as clear cell RCC to these therapies. You can see here again, pathology speaks for itself, where you can see you have clear cell RCC that expresses very, 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 very often, as you guys know very well, CA9, which is literally a direct target mainly of HIF1, and GLUT1, which is also a direct target transcribed through the influence of HIF. And of course, you can see how there is the overlap between the clear cell RCCs defined by the CA9 expression and vasculature as defined by CD31. Clear cell kidney cancer loves to make blood vessels around it. Now, this is different from the third most common kidney cancer, chromophobe renal cell carcinoma. And Liz Hensky, Ari Hakimi, and others wrote a very, very, very nice overview in Cancer Cell recently, described some of the hallmarks of chromophobe renal cell carcinoma in the hopes of catalyzing dedicated clinical trials for this disease. And one thing that we all know, and certainly from a pathologist standpoint, something is off with the mitochondria of chromophobe. Every kidney cancer really has some deregulation of its bioenergetics, including its mitochondria, but definitely chromophobe and oncocytomas do have deregulation of the electron transport chain, probably because of mitochondrial mutations versus other alternate metabolic profiles. What is that telling us? This is telling us that this is not a pseudohypoxic phenotype. So yeah, sure, the anti-VEGF therapy agents developed for clear cell renal cell carcinoma can occasionally work, but they're not truly targeting the biological hallmarks of chromophobe RCC. And from this, we can predict that neither would HIF2 alpha work for chromophobe RCC. Data remain to be seen. If it does work, that will be surprise, which means that it's going to be information. Chromophobe does require, for example, increased glutathione to combat the oxidative stress associated with its mitochondrial deregulation, and cysteine depletion is one way to decrease glutathione, leading to cell death that is of interest. Then a third key hallmark of cancer recapitulated by renal cell carcinoma subtypes is actual hypoxia, not pseudohypoxia. And the perfect model is RMC. RMC is the deadliest kidney cancer in adults. It's completely resistant to the anti-VEGF agents that we give for clear cell renal cell carcinoma. It's like giving them toxic water. And the currently available immunotherapies, as we just presented to the AACR conference, actually feed RMC, so they make it grow faster. It's a very interesting cancer because it mainly afflicts individuals of African descent, not because they're Black, but because of its connection with sickle hemoglobinopathies, including sickle cell trait, sickle cell disease, SC, and sickle beta. Median age is in their 20s, and it's always, always, always defined by loss of the SMARCB1 tumor suppressor. It's a rare cancer, but there is 3 million individuals with sickle cell trait in the United States, and I see about 3 to 5 cases of RMC per week in my clinic. Occasionally, it may go even up to 9. And there is 300 million individuals with sickle cell trait worldwide that are at risk for RMC, mainly in Africa and in India. So it's very, very, very likely that this cancer is underdiagnosed. Now, this cancer is defined by hypoxia and ferroptosis as its hallmarks. It was born under hypoxia. It doesn't care if you take out its blood vessels. What's the pathology connection? Just take a look at how it looks. It's a highly desmoplastic tumor, doesn't have a lot of blood vessels. You can predict just from the morphology that this is not going to respond to the anti-VEGF TKIs. I didn't even need to tell you that. And you can predict, although the data remain to be seen, that HIF-2 alpha inhibitors likely, unfortunately, will not work against this subtype. Part of its resistance, actually, as we recently published in PNAS, is the SMARCB1 loss. So kidney cells in the loop of Henle, which appears to be the site of origin of RMC, and in the medulla, actually downregulate SMARCB1 to protect themselves from low oxygen. So when they lose completely SMARCB1, they no longer care about low oxygen, neither about ferroptosis. So that's the mechanism behind it. So already from this high-level overview, you can get some sense of what we would expect clinically to happen when we target HIF-2 alpha across these subtypes. Clear cell RCC, the perfect prototype. F8 deficient RCC, whether sporadic or hereditary associated with HLRCC, should respond, but data remain to be published. And maybe the type 2 papillary sometimes can be associated with pseudohypoxia through either pathways, but less likely. And ST8 deficient entities potentially as well. That's why there are actual trials just focusing on these entities with HIF-2 alpha inhibitors. RMC should not, for example, respond. And you can see here, this is a very nice slide where it shows also how, as far as we can tell, there is a little bit of controversy, but I would say most experts believe that in clear cell RCC, HIF-1 alpha appears to be tumor suppressive, whereas HIF-2 alpha is the oncogenic one. Hence why in clear cell RCC, we target HIF-2 alpha and not HIF-1 alpha. For example, RMC, because of its association with actual hypoxia, has upregulation of HIF-1 alpha. We don't yet know if that's a driver. And so once this was identified in clear cell RCC, the first ever robust preclinical data were published in Nature in 2016 using PT2399, the tool compound, showing very nice response in preclinical models of clear cell renal cell carcinoma by targeting HIF-2 alpha. This is the first robust HIF-2 alpha antagonism effort by Peloton Therapeutics at the time. And so that was the tool compound. The clinical compound was tested, and it was PT2385. That's the clinical compound, was tested in a phase 1 dose escalation and expansion trial in 51 patients with heavily pretreated sporadic clear cell renal cell carcinoma. Now, the thing that was discovered clinically is that this compound had high metabolic liability leading to highly variable drug exposure. You can tell it from here. You can tell that you've got some of these patients that got low doses, but in fact, pharmacodynamically and pharmacokinetically, they had much higher exposure and better responses. And there was this evidence that the higher the drug exposures, the better the clinical outcomes, but the actual exposure was a little bit random. And so that needed improvement. And it was that chemical improvement that led to the next version of these molecules, called at the time PT2977 and now known as belzutifan. And again, a similar dose escalation and expansion trial in 55 patients now showed response. The belzutifan lacks that metabolic liability of its predecessor, and belzutifan causes on-mechanism toxicities. Its classic toxicities that we're seeing across settings is anemia, manageable, and hypoxia, also typically manageable. The difference with anti-VEGF TKIs is the lack of cardiotoxicity. So things like high blood pressure, CHF exacerbation, etc. You don't see any of those. And no wound healing issues. So whereas with anti-VEGF TKIs, we get into trouble with wound healing, not with belzutifan. The other interesting aspect about belzutifan, though, is that responses develop slowly over many months of therapy. So you gotta give it time before it actually acts. And so after this data were seen in this initial trial, and this is a slide courtesy of Eric Jonas at MD Anderson, the first effort was to make a registrational study for belzutifan that most of you are aware of in VHL disease, leading to its approval in VHL syndrome-associated renal cell carcinoma. And then the next registrational study in pre-treated sporadic clear cell renal cell carcinoma, leading to FDA approval on December 2023, as I mentioned. And now what this is leading to is to a second dose optimization study. The approvals here were using 120 milligrams daily of belzutifan. This one is testing 120 versus 200 milligrams to see if, we can get away with higher doses and get better outcomes. And of course, now belzutifan is being combined with other drugs, including lenvatinib versus cabozantinib alone. So belzutifan plus lenvatinib versus cabozantinib, with immunotherapy, including anti-PD-1 immunotherapy with pembrolizumab and anti-CTLA-4 therapy by Merck. And in the adjuvant setting, many of you know that adjuvant pembrolizumab was FDA approved based on Keynote 564 trial in renal cell carcinoma in the adjuvant setting. There's a trial now testing the addition of belzutifan there. And also because of some synergistic data in preclinical models of targeting HIF-2 alpha and cell cycle pathways, there is a trial testing the efficacy of palbociclib plus belzutifan. And there is also the testing of a triplet therapy across solid tumors, and of interest now in the more pseudohypoxic ST8 deficient setting. There's the belzutifan in pheochromocytomas and paragangliomas now ongoing. So the one that is of key interest to today's session is the VHL syndrome approval of belzutifan. And this is a very nice way of breaking things down, taught to me by Ram Srinivasan at the NCI, whereby what is it that you want to do when you're dealing with, VHL syndrome? Well, one of the things that you want to do is you want to minimize risk of metastasis from clear cell renal cell carcinoma, PNETs, and pheochromocytoma, and also control potentially rare, but they can happen, systemic complications from pheochromocytoma. So these are systemic goals that you have where you want to position systemic agents. So clear cell RCC, number one goal, in the VHL syndrome setting, objective response rate almost 50%, and the other 30 patients had ST as best response. So pretty good responses. The responses actually in the VHL syndrome patients, VHL-associated clear cell RCC may be more profound than what we may be seeing in the sporadic setting. There are many potential successes with that. Pancreatic lesions, very, very, very good responses, including the PNETs. Very, very strong signal of responses with belzutifan. And that's why in the package insert, you will see that this is an indication for using it. Now, pheochromocytoma, they did not have enough numbers, limited efficacy data. So formally, it's not, it should not be used just for pheochromocytoma, but there are trials, as I mentioned, looking into this. And the other thing that you want to do in VHL syndrome is control the local symptoms that you might get from the local growth of CNS and retinal hemangioblastomas and endolymphatic sac tumors that can cause hearing loss, etc. So in that context, there are responses in the registrational belzutifan trial in VHL, an objective response rate of 30% in hemangioblastomas and 3 complete responses. And but the data in the retinal hemangioblastomas were lacking due to incomplete assessment. So that's why the FDA did not mention the use of belzutifan there. But our own internal experience suggests that belzutifan is pretty good with hemangioblastomas all around, even though, this is yet to be formally shown. The only patient that had the endolymphatic tumors was endolymphatic sac tumors, had SD, so limited efficacy data, more to come hopefully in the coming years. The registrational study that for sporadic clear cell renal cell carcinoma was the 005 study that tested in the salvage setting heavily pretreated patients, belzutifan versus everolimus, and you do see a significant improvement in PFS, and you see a signal as well, although not as strong, interestingly, and there are many potential explanations why that is, in OS, even in this later setting where you should not have as much confounding by post-progression therapies. The objective response rates are definitely higher with belzutifan versus everolimus. I personally always like, because I know that everolimus can help with prolonged OS and it can help control the disease, but not necessarily shrink it. I like to combine everolimus with lenvatinib to give an extra oomph to the therapy. And then given how tolerable belzutifan is, you can give it in patients who are sick and are heavily pretreated. Now it's FDA approved. I like to give it last. It's a nice agent to give when you don't have anything else to give for now. So when we're, given the very, very nice translational efforts to target HIF2 alpha, there are efforts as well to establish biomarkers and elucidate resistance mechanisms. Currently, there are no established robust biomarkers to predict which VHL defective clear cell RCCs are more likely to respond to these inhibitors. Interestingly, there are early, very nice signals showing that there is acquired resistance to belzutifan due to HIF2 alpha mutations that prevent binding of belzutifan to HIF2 alpha, and HIF1 beta subunit mutations that increase the affinity of HIF2 alpha to HIF1 beta. And it remains to be determined how often these mutations will arise clinically. They have been observed clinically with belzutifan use. And also now looking a little bit more to the future, there are other HIF2 alpha inhibitors in the pipeline. There is one by Arrowhead Pharmaceuticals, which is different in the sense that it's an siRNA-based agent that decreases HIF2 alpha expression. We participated in the trial. The results will hopefully be published soon. Novartis had a HIF2 alpha inhibitor similar to belzutifan, binds the same HIF2 alpha pocket, but it discontinued its development very recently. NKT 2152, similar again to belzutifan, ongoing development. We have the trial open here. We're enrolling patients as well. And the newer one is casdatifan by Arcus Bioscience. Again, similar to belzutifan. In theory, may have better pharmacokinetic properties. So instead of seeing late responses, they hope to see a greater oomph by early responses. We'll see what happens clinically. So in summary, HIF2 alpha blockade is reasonable in tumors driven by pseudohypoxia. Belzutifan is well tolerated and lacks the cardiovascular and wound healing adverse events of the anti-VEGF TKIs. It does have slow response kinetics. It has been FDA approved in sporadic and VHL-associated clear cell renal cell carcinoma. And I would like to acknowledge the team. This is a team effort discussing these things, doing preclinical testing of HIF2 alpha inhibitors as well in my lab, and brainstorming all of these with people from both within MD Anderson and across the country and the world. And I also would like to acknowledge our funding agencies and thank you again for the kind invitation, and happy to answer any questions you might have.
Thank you, Pavlos, for the illuminating talk. I think all of us as pathologists will find that very helpful. So we are very appreciative. I would also like to thank all the speakers, Virginie, Tatiana, Mark, and Pavlos again for the fantastic discourses and sessions. We do have a few minutes for hopefully one session from each speaker. Dr. Antich, could you please comment upon, in the daily clinical practice for most pathologists who do not have probably molecular sequencing or molecular tools available, how do you handle or sign out renal tumors or clear cell renal tumors with fibromuscular stroma?
That's a very good question. Usually, I sign them out as unclassified renal cell carcinoma with clear cell phenotype and prominent fibromuscular stroma, see comment. And then I say that the staining shows this, this, and that, and therefore differential diagnosis includes this and this, and that molecular study is recommended for further evaluation. That's how I signed this out. Although, as you know, for LOC mutated cancer, you have to have mutational confirmation if you are going to call it LOC mutated. And these TSC tumors actually are not even recognized in WHO, therefore you cannot even call them anything. That's how I personally sign out, but I assume that other people have different ideas how to do that.
Would you communicate with your clinical team and bring out the possibility that a subset of these tumors might have hereditary annotations? Would you convey that to them?
Yes, definitely. And because we have tumor boards and we often discuss these cases, I would say, hey, does this patient has, because it's a young patient and has maybe multifocal tumors, does this patient have any other hallmarks of specific, let's say, tuberous sclerosis syndrome complex findings? And this is kind of two-way discussion that we always have. But yes, I do mention that in my comment also.
Thanks, Dr. Antich.
So to follow up on Dr. Mehra's question, I have a question for Dr. Ball. In the context of tuberous sclerosis associated tumors, would your 3 centimeter criteria hold? Would you incorporate ablative treatments or medical management? Would you tailor it differently?
Yeah, great question. TS can be challenging because we have to first separate management of AMLs, angiomyolipomas, from RCCs that arise. And we see AMLs a lot more, right? So with AMLs, we often do surveillance. Sometimes these are radiographically very apparent. And so that makes our job easy. When they are don't have the typical radiographic appearance of an AML, we will often use a biopsy to see if we're dealing with AML or an RCC. If it is RCC, we often we do stick with the 3 centimeter rule. I have a bias towards surgical resection. Obviously, I'm a surgeon, over ablative therapy for a few reasons for patients with any type of hereditary kidney cancer syndrome, because one, we can usually, one, we have the tissue, so we know exactly what we're dealing with. 2, it makes follow-up a little bit easier because we don't have a dead part of the kidney that we're trying to surveil. So that's how I think about TS.
Dr. Ball, can I ask you a question? So when we talk about active surveillance of renal masses, and so what is the growth rate, which is the threshold? What threshold would you kind of use to kind of change from active surveillance to a surgical intervention? So is there a growth rate threshold that you use as a cutoff?
Well, for example, for VHL, our growth rates are typically between 3 and 5 millimeters a year. So if we see something growing faster than that, that's going to be in sort of the top 25% of growth rates. We're going to keep our eyes on it for sure. If something is not yet 3 centimeters, but it's growing quickly, we're going to surveil them pretty quickly. But the growth rate itself is often not a trigger. It's really the absolute size in most cases.
And do you kind of, in your practice, do you get biopsies done beforehand before you really kind of think about how to really manage these patients?
Good question. For hereditary kidney cancer, usually not, because we there's a pretty strong correlation with, if it's VHL, we know it's a clear cell tumor, right? But for a sporadic renal mass, we still don't use biopsy as much as we should. But for challenging cases or ones where we're really trying to decide between a radical nephrectomy and a partial nephrectomy, I absolutely biopsy those, because I think that can make a big difference if we know how oncologically worried we are about a tumor.
One question in general we have for all the speakers, if anyone would care to probably address or can possibly address, is anyone at the pathologic or clinical level using BAP1 immunohistochemistry currently to prognosticate renal tumor subtypes? Virginie, please go ahead.
Yes. I told to Tatiana Ortik that I used to perform BAP1 just for fun, because sometimes it's beautiful when it lost, but clinical actually don't care about loss of BAP1, and I'm not sure that today it changed anything in the clinical care, but maybe tomorrow. I think that we have to be very careful for this case because they have bad prognosis.
Thanks. Pavlos, would you like to make any comment regarding this?
Yeah, and in fact, I was typing. I saw, the question. I think that BAP1 IHC is useful. Thankfully, we have the NGS, so in the vast majority of cases, the NGS will show us the mutation. It is important because prognosis and prognostication is key to decision making. If you have a patient that knows that they have a more aggressive clear cell RCC because they have BAP1 mutation, as opposed to, a PBRM1, clear cell RCC, that can change the way they think about, their prognosis, what's going to happen next, etc. So I actually do find it useful to know whether a tumor is BAP1 mutated or not.
I actually do BAP1 immunohistochemistry, especially on tumors that morphologically I recognize as BAP1 because I study those. And I often put the comment saying that BAP1 stain is lost, however, it should be confirmed molecularly. And I always put this comment that BAP1 mutation in a TCGA data is like individual factor that predicts poor prognosis. Therefore, I think it's very important for them to know that.
Thank you.
So with that, I just wanted to say that we're at time and we want to be respectful of everybody's time. If the panelists could just stay back for a few minutes. And once again, I'd love to thank all of the speakers for excellent talks and for everybody's engagement with asking the questions. Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you to all of you. I'm going to end the recording in just a moment, but was hoping each of you could look at your camera so we can get a picture. Those of you who have not seen it yet will notice that you have been tweeted or posted on X and as much as possible tagging your institutions and colleagues so that they know of this session. Really, thank you for a really excellent session. And I'm going to grab a picture now so everybody focus towards their camera. Okay, thank you so much.
Thank you.
Thank you.
Thank you very much.
Thank you very much.
everybody.
Pleasure.
Thank you.
Bye.
Bye-bye.
And see you at Chicago, Tatiana.